I would like to thank first the organizers for having invited me and giving me the opportunity to speak here. These are my disclosures. This is a list of, in my view, key frontline RCTs that had been performed in the elderly by treatment era. And the concept of dividing our patients in the younger ones and the older ones, I think, did not evolve before the time when we started to escalate chemotherapy in our patients. That was done actually in one single trial, the CLL5 trial, published years ago by Barbara Eichhorst. And that concept peaked in the chemoimmunotherapy era with FCR, it's just shown, becoming our standard treatment with very good efficacy, but also some substantial toxicity risks, of course. And now we are entering an era where a question is coming up whether we need that concept anymore, dividing younger versus older patients in the inhibitor era. Now, as you can see from the program, all the trials that are listed below here, the 4 trials with inhibitor treatment, will be presented in detail later on during this session. And I was reminded by the scientific committee of the Congress that this is a global meeting and that inhibitor treatment is not readily available in all of these countries and regions. So I was asked to set the stage for the later presentations of these trials and to concentrate on what was before until end of 2018. If we look to these trials, you can see that they were quite homogeneous with regard to median age, that was around 70 years, and also with regard to ECOG performance status, which was remarkably low, 0 to 1 or so. There was some heterogeneity, however, with comorbidity burden, as measured by SIRS or any other means. Now, our first attempts to improve treatment in elderly patients by just escalating chemotherapy were not so successful. And the first true advancement was indeed the introduction of chemoimmunotherapy, not just for younger patients, but also for older patients. And that has been done in 2 internationally conducted trials. That was the Complement 1 trial comparing chlorambucil monotherapy with chlorambucil plus ofatumumab treatment. And the other one was CLL11 comparing chlorambucil with chlorambucil rituximab or obinutuzumab. And these are the curves from the initial publications showing superiority of the chemoimmunotherapy over chemo alone. Here are the updated numbers with a 5 years follow-up, and you can see that for PFS, the data remained stable and still showed that superiority in PFS, that was the primary endpoint of these trials, for CIT versus CT. With regard to overall survival, there was some heterogeneity, but with a modern antibody, there was also overall survival for the chemoimmunotherapy over chlorambucil alone. So for those regions and countries where inhibitors are not available, I think it's important to know that it does not always take an inhibitor to improve survival. If the goal is to just give something better than chlorambucil and improve survival of the patients, it's also possible with an antibody. Conversely, I disagree with voices saying that it takes nothing to be better than chlorambucil with regard to overall survival. It's shown by all the older trials where escalating chemotherapy using FC, for example, fludarabine, bendamustine, or even alemtuzumab failed to improve overall survival over chlorambucil. So I think it's still an important observation. Obviously, it needs a modern drug to improve survival compared to that very old drug. Now, having proved the superiority of chemoimmunotherapy over chemotherapy in elderly patients, there was, of course, room for improvement. And one approach is and was, of course, to use FCR, which was our standard treatment in younger patients, in a dose-modified manner. And I've just listed here studies or case series including such frontline therapy with dose-modified FCR. And as you can see, this was mainly done in non-randomized fashion in these trials or case series. The numbers of the studies varied remarkably, and I would say preferentially these trials were done in a rather non-comorbid patient groups. I just want to highlight again the trial that Florence Cimbalista just mentioned, which was on the rituximab maintenance, because this is, to my knowledge, the only rituximab maintenance trial that was explicitly done in elderly patients. And what has already been shown is that in that trial, rituximab maintenance improved progression-free survival in these elderly patients that were fit but elderly. And here there is a split up with regard to mutational status. And as you can see, by using this rituximab maintenance therapy in this trial, that lifted a little bit the curve of the unmutated patients. And that is, I think, a phenomenon that we currently discuss also again with the modern inhibitor trials. I think it's a quite remarkable result in these patients. Now, in my country and in many other countries, as I know, bendamustine rituximab is a favorized regimen used in elderly patients, and that is based on the one hand side on the CLL-10 trial of the German CLL study group, which was not a trial specifically designed for elderly patients, but in the subgroup analysis shown here, the inferiority of bendamustine compared to FCR was not that big than in the younger patients, and the rate of toxicity, especially the rate of grade 3 to 5 infections, was remarkably lower with BR compared to FCR. It was around 20%. Now, there was the so-called MABEL trial, a trial that compared bendamustine rituximab with rituximab chlorambucil, and that was done in elderly patients with some moderate comorbidity burden. And it was interesting to see that here again the grade 3 to 5 infection rate was again around 20% or so, so it was doubled compared to the RCLB arm in this trial. So obviously replacing CLB by B in this setting increases the infection risk, and this is also supported by some cross-trial comparison where again the rates of severe infections was around 10 to 15% or so with the chlorambucil chemo backbone. Of course, on the other hand side, bendamustine rituximab is superior to chlorambucil rituximab with regard to progression-free survival, which was not the primary endpoint in this trial. But anyhow, you can see the curves. There was a marked difference here. Interestingly, replacing CLB by B did not result in an overall survival benefit here. Now, CLL-11 was by itself also a chemoimmunotherapy optimization trial for elderly patients. Here there was no exchange in the chemotherapy backbone, but the antibody, of course. And these are, again, the data. And you can see that progression-free survival was doubled compared with the obinutuzumab antibody compared to the rituximab antibody, and that translated into a clinically meaningful time to next treatment, which was around 5 years on average, which is, I think, a very relevant observation when we think of treating elderly patients around 70, 75. 5-year treatment-free period is relevant to these patients. Now, more importantly, I think, is the observation that in this trial, the use of the antibody was also relevant for overall survival, which was longer with obinutuzumab treatment compared to rituximab treatment. So, in my view, this shows us that the quality of anti-CD20 targeting can modulate survival in CLL, and that might be an observation that is important also when we now talk about inhibitor treatment. This effect is probably, that's at least my interpretation, driven by MRD negativity that is easier to achieve with a type 2 glycoengineered antibody compared to type 1 antibodies such as rituximab. So now we have the already mentioned new trials comparing chemoimmunotherapy in elderly patients with inhibitor treatment. And as already said, you will see these data in detail in a few minutes. I've been thinking about the questions that may arise from these data. One question that sometimes comes up is whether treatment used in the standard arms of these trials were adequate for fair comparisons or still too weak. And I hope that I could convince you that the chemoimmunotherapy arms and regimens used in these trials were not so bad, and in my view they were adequate for these comparisons. Another question is whether we still need anti-CD20 antibodies at all in the inhibitor era. This cannot be answered, of course, by these trials, nor can it be answered by earlier chemoimmunotherapy trials. We need new trials for that. But based on that, what I just told you, I think it's too early to abandon the anti-CD20 principle from our treatment concepts in the inhibitor era. A final question, do we still need this differentiation between young and elderly patients? Does it still matters? Well, there are data suggesting that elderly and comorbid patients equally benefit from using inhibitors treatment compared to the standard treatments we have. This has been shown in mixed trial data, but also from retrospective analysis. One example is shown here on the left side for idelalisib treated patients. On the other hand, obviously, while comorbidity is not predictive when measured by SIRS in these examples here for treatment benefit, it obviously stays prognostic, and that, of course, gives some room for treatment improvement here, particularly if there are severe comorbidities. Who are these patients who have severe comorbidities? Well, I think on the one hand side, these are the oldest old patients, patients over 80 or even in their 90s. We still do not really enroll these patients to our trials. This is an analysis we did for the German CLL study group randomized trials performed in the last years. And as you can see, the number of patients over 80 enrolled to these patients, although you see in all the patient characteristics the range that is above 80 was around 4% or so. So that's clearly below what we see in real world for these patients. Do we include true geriatric patients in our trials? Well, unfortunately, we have not so many trials where we really assess geriatric features in our patients. This is from the Alliance trial that's taken from the appendix of the New England publication by Jennifer Voyach. I want to congratulate the authors and conductors of the trial, because to my knowledge it's the only randomized trials in elderly patients in CLL we have so far where a geriatric assessment has been done, a full geriatric assessment. If you study the numbers, however, then you see that virtually all of the patients were unimpaired in geriatric domains such as activities in daily living, mobility, cognition, etc. So we still, I think, are not good enough to really include geriatric patients in our trials in a substantial number. So here's my conclusion slide. I think if inhibitor therapy is unavailable, or of course if your patient, if it's unavailable, you should use validated chemoimmunotherapy regimens as frontline treatment in your elderly patients. And the evidence is not equally distributed over the fitness levels we have in that particular patient groups. I think we have strongest evidence for the BR regimen and the GCLB regimen, depending on whether you have a rather fit or an unfit patient. Of course, if your patient has high-risk features, then all of this will not work, and inhibitor treatment is a must. Then, as I showed you, quality of CD20 targeting could not just impact PFS, but obviously also MRD and thereby OS. So I think it's relevant for the design of future MRD-guided or fixed duration treatments that are discussed during this meeting. And finally, I just want to highlight again the lack of evidence and unmet medical need in the geriatric population, so those patients being 80 or above or having background frailty. You can say that's a small number of patients, but in fact it's 5 to 15% of all of our patients, so it's the same size as our high-risk patients. And I think the question is really how we treat those patients in the new era with inhibitors and with which ones. I would like to thank all my co-workers at my institution and at the German CLL study group, and I thank you for your attention.